Welcome to this presentation on an educational program for primary healthcare providers on reducing the overuse of antibiotics for upper respiratory infections. My name is A.Onwuemene, a candidate for Doctor of Nursing Practice. I am a family nurse practitioner and I work in primary care. Following the completion of this program, the learner will be able to understand the historical developments of antibiotics, explain antibiotic resistance and complications associated with antibiotic resistance, identify the appropriate use of antibiotics, discuss the significance of educating patients on the importance of reducing antibiotic use, and understand how to implement the Center for Disease Control and Prevention outpatient treatment recommendation and the American Family Physician antibiotic use in upper respiratory infections when treating patients. Background and history of antibiotics. In 1928, Alexander Fleming discovered penicillin, the first antibiotic derived from fungi. Before the discovery of antibiotics, the average life expectancy was 47 years, and people died from infections such as gonorrhea, syphilis, strep throat, pneumonia, and so on. Following the introduction of penicillin, additional classes of antibiotics, including cephalosporins, tetracyclines, and fluoroquinolones, were developed. However, since the discovery of antibiotics' effectiveness, there has been a common misconception that antibiotics can be effective for various illnesses. As a result, antibiotics are incorrectly prescribed and used. According to the Center for Disease Control and Prevention, CDC, nearly 30% of the prescribed antibiotics are deemed unnecessary in the outpatient settings. There is a lack of knowledge on proper antibiotic prescription and use in primary care. Various reports indicate that many upper respiratory infections are viral in nature. When antibiotics are used in farm animals and plants, antibiotic resistant bacteria spread through agricultural produce, posing a global threat to both health and food security. More than 35,000 lives are lost to antibiotic-resistant infections yearly. Additionally, antibiotic-resistant infections result in a yearly economic burden exceeding $4.6 billion. It is essential to understand the concept of antibiotic resistance. An antibiotic resistant mechanism occurs when mutant bacteria modify, deactivate, obstruct, or expel the target antibiotic. These mutant bacteria multiply, evade the host cell, and infect other bacteria. This means that antibiotics do not eliminate all bacteria during an infection. The bacteria that survive undergo genetic changes. As a result, when the same antibiotic is used again, this mutated bacteria can resist the antibiotic's effects and in some cases even expel the antibiotic from the cells. Factors that contribute to antibiotic resistance include not following guidelines such as prescribing antibiotics for viral infections and not providing symptomatic treatments such as prescribing antibiotics for allergy symptoms. Another issue contributing to antibiotic resistance is excessive reliance on empiric treatment, which involves treating patients with antibiotics based on the presented signs and symptoms without using a diagnostic test for confirmation. Patient ignorance also contributes to antibiotic resistance. For example, stopping the use of antibiotics after just 2 days when a 5-day course has been prescribed. Antibiotic resistance can lead to life-limiting or life-threatening infections that are difficult to treat. Such complicated infections are diarrhea caused by Clostridium difficile, penicillin-resistant meningococci, ceftriaxone-resistant gonococcal, and more. At this point, it is important to define an essential part of antibiotic resistant management, which is antibiotic stewardship. So, what is antibiotic stewardship? Antibiotic stewardship is an initiative that tracks and enhances the way antibiotics are prescribed by providers and used by patients. Local and academic health agencies should collaborate to provide educational support to nurses, physicians, and students to enhance the proper prescribing of antibiotics. Additionally, healthcare authorities can enforce accountability for monitoring antibiotic prescriptions and resistance in clinics, pharmacies, and laboratories. These facilities can implement strategies for monitoring monthly antibiotic use and set quarterly benchmarks to reduce unnecessary antibiotic prescriptions. Therefore, the healthcare system can implement an antibiotic monitoring practice involving providers and patients to ensure adherence to guidelines for prescribing and using antibiotics for upper respiratory infections. Indication for prescribing antibiotics for upper respiratory infections. When considering prescribing antibiotics for upper respiratory infections, it is important to look for collective signs and symptoms such as double sickening, purulent nasal discharge, or fever of 102 degrees Fahrenheit or higher, lasting for 10 days or more in the case of rhinosinusitis. Antibiotics should be prescribed with a diagnosis of strep pharyngitis. With strep pharyngitis, patients will typically exhibit signs and symptoms such as tonsillar exudate, anterior cervical lymphadenopathy, sore throat, high fever, and the absence of a cough. It is crucial to differentiate mononucleosis from strep pharyngitis due to their similar signs and symptoms. Mononucleosis is caused by viruses, while strep pharyngitis is caused by bacteria. Unlike strep pharyngitis, mononucleosis typically present with posterior cervical lymphadenopathy rather than anterior cervical lymphadenopathy. Both conditions involve signs and symptoms such as fever and sore throat. Mononucleosis is also characterized by an enlarged spleen and fatigue. For improved clinical decision making in managing upper respiratory infections, point of care testing should be performed in the office. Point of care tests are easy and fast diagnostic devices. Examples are rapid strep test, monospot test, rapid COVID-19 antigen test, and so on. In the absence of a diagnostic test, it is crucial to consider the likely source and refer to regional guidelines and local susceptibility data to select the most effective antibiotics and limit the chances of renal or liver toxicity and allergic reactions. Healthcare providers are responsible for educating patients on reducing the use of antibiotics. Patients should be educated on their personal health risks, which includes age and immunocompromised status. The patient should be instructed to stay up to date with recommended vaccines such as COVID-19 flu, pneumococcal RSV vaccines, and more. Also, the patient should be instructed to practice proper hand washing and only use antibiotics when necessary and prescribed. Ensuring the right dosage and duration of antibiotics is essential even when symptoms improve, and patients should refrain from sharing and borrowing antibiotics. It can be challenging for patients to know how to manage illnesses. Therefore, patients should consider the following tips for upper respiratory infections. Runny nose, sore throat, and cough requires symptomatic treatment. Worsening symptoms and high fever requires calling the primary healthcare provider. And difficulty breathing and chest pain requires going to the emergency room. The primary healthcare provider can provide patients with printed informational materials on upper respiratory infections. Barriers to antibiotic stewardship for upper respiratory infections include a lack of trust between patients and providers. Healthcare facility politics also pose a barrier with pressures to treat as many patients as soon as possible in a limited time frame. Also, facility politics involves purchasing a limited amount of point-of-care devices to increase revenue. This results in some outpatient clinics lacking point-of-care devices. Even when available, the allocated patient visit time of 10 to 15 minutes may not be adequate for this additional task. The CDC outpatient treatment recommendation for upper respiratory infections are as follows. Viral sinusitis has headache, clear to whitish nasal discharge, and nasal congestion. The management for viral sinusitis is watchful waiting. Acute bacterial rhinosinusitis can be diagnosed when there are 3 or more days of fever equal to or greater than 102 degrees Fahrenheit, along with purulent nasal discharge. The first-line treatment for bacterial rhinosinusitis is augmentin or amoxicillin. In case of penicillin allergies, doxycycline could be used. Uncomplicated bronchitis requires ruling out pneumonia with abnormal vital signs and lung examination. Symptomatic treatments such as cough suppressant and/or antihistamine, rest, and fluids is recommended for uncomplicated bronchitis. Strep pharyngitis can be diagnosed with 2 or more central criteria, which includes fever, tonsillar exudate, cervical lymphadenopathy, and no cough. The rapid strep can be used as point-of-care testing. Amoxicillin is a first-line treatment for strep pharyngitis. Mononucleosis is commonly caused by Epstein-Barr virus. It is characterized by posterior cervical lymphadenopathy, sore throat, fever, fatigue, and enlarged spleen. Supportive treatment is the primary treatment for mononucleosis. For colds and nonspecific upper respiratory infections, decongestion and nonsteroidal anti-inflammatory drugs are recommended. The recommendations from the American Family Physician regarding antibiotic use for upper respiratory infections are as follows. COVID-19 diagnosis using point-of-care testing warrants supportive care. Paxlovid is recommended for high-risk population with mild to severe cases. Uncomplicated acute otitis media should be managed with watchful waiting. However, amoxicillin may be prescribed for severe or bilateral ear infections. Influenza diagnosis using point-of-care testing requires supportive care. Tamiflu is recommended within 48 hours of flu symptom onset. Management of laryngitis with fever, hoarse voice, sore throat, and nasal congestion involves supportive care. Excessive use of antibiotics for upper respiratory infection is a serious issue in primary care. It has led to antibiotic resistance, longer hospital stay, higher healthcare costs, and diminished quality of life. Addressing this issue through primary healthcare provider and patient education is crucial for reducing antibiotic resistance and improving clinical outcomes. For more information on upper respiratory infections, visit the CDC or the American Family Physician websites. For any questions and comments, I can be contacted at adebosolo.owemene@wagner.edu. Thank you for your time and attention.